Good morning to my friends in the US. Good afternoon to all of you in Europe, and good evening for people in Asia, because we have a crowd listening at us from Asia. I'm Dominique Gress, the executive editor of IMCAS Academy, and I'm very, very happy to greet you for this webinar dedicated to updates in alopecia. And thanks to a lot of new therapies coming into this domain, which is very, very exciting. In a minute, I'm going to talk about the program, but first, I would like to give you a little update about what is IMCAS Academy. IMCAS Academy, in a nutshell, this is the online version of IMCAS Congress, as you all know. It's a very, very rich community with almost 40,000 doctors all over the world. There is a very rich content on IMCAS Academy where you can find clinical cases, where you can find exclusive video. There is a blog with over 200 articles, and there is CME accredited course. And on top of this, you know that IMCAS Academy is doing a lot of webinars. More than once per week, we have webinars. So this is a very rich community. On top of this, there is a very interesting product service that we give to doctors all over the world, which is called IMCAS Alert. In a nutshell, what is IMCAS Alert? If you are facing a complication or a challenging case, you have the possibility to directly link with the community of IMCAS in order to ask questions, to ask some help. So how does it work? IMCAS Alert has been regrouped into 5 main subjects. First, this is injectable and threads. Then there is a group concerning lasers, MBDs, and peeling. Then a group concerning genital treatment, a group concerning plastic surgery, and a group concerning clinical dermatology. So the first thing that you have to do is you have to connect with these groups and become a member. This is free of charge. This is a completely free of charge service. And when you have joined group, you can post your case, ask questions concerning your complication that you are facing. You are describing your case, and you can interact. And sometimes within seconds, minutes, or hours, the entire community of IMCAS is helping you or providing you the answer. So I will really encourage you to join the IMCAS Alert community, because it is one of the most hot topics, if I may say, of IMCAS as a whole. Okay, so IMCAS Alert, a free service from IMCAS Academy. So today we are going, as I was saying, we are going to talk about alopecia, the changing world of new therapy, and I have the chance and the honor to be the moderator. So I will have a little bit maybe the dark side of it. So in order to make sure that all speakers remain on time, I remind you 12 to 15 minutes for each of the presentation. And I have the honor to present also Dr. Pierre Bouana from France, which is going to moderate and share this webinar. Good afternoon, Dr. Bouana.
Good afternoon, Dominique. It's a pleasure.
So we will start with Dr. Sergio Vrano from Spain, which is going to talk about new medical therapy for androgenetic alopecia. Good afternoon, Sergio.
Good afternoon, Dominique. It's my pleasure to be here.
And it's my pleasure to have you again here, Sergio. Then we will talk about a new class of treatment. If you are busy into dermatology, everyone is hearing about JAK inhibitors, about definitely first indication, it is in atopic dermatitis. Then we are going to have in vitiligo. Then it's coming also in alopecia and numerous other skin-related indications. So we are going to listen at Dr. Sadiq from the US, which is going to update us. So good morning, Neil.
Good afternoon. How are you, Dominique? It's a pleasure to be here this afternoon. I wish everybody good health and good hair.
Thank you. Good health and good hair. So that's a good wish, yeah, especially for me, maybe. And then we'll have, last and not least, a very interesting presentation about frontal fibrosis alopecia, lichen planopilaris, and folliculis decalvans. And we will have Dr. Benin Borul from Australia. Good evening for you, Dr. Borul, because it is the middle of your night, right?
Good evening. Well, I'm not in Australia at the moment, so I'm closer to French, to Paris time. So
okay, good for you.
Thank you for the invitation.
But you are based normally in Australia, if I'm not wrong.
Yes.
So,
yeah.
Dr. Buena, do you want to say a little word before handing over to the first speaker, to Dr. Sergio Vano? Do you want to say something?
Well, Sergio Vano has done many studies about all the newest treatment for hair and particularly for androgenetic alopecia. So it's very important for us to listen and then to ask questions, because there are so many new procedures that we have to be to observe the efficacy and the good tolerance of each treatment. So it's my pleasure, Sergio, to listen to you.
Sergio, I just want to add something, because Dr. Buena mentioned about question. I forget to say, we will take question after each lecture. So during the lecture, if you have a question for each of the speakers, please go on the chat area and put your question, and we'll ask your question to the relevant speaker. Sergio.
Thank you very much, Pierre, for the kind presentation, and thank you very much. It's my pleasure to be here again at the IMCAS Academy, and we're going to talk today about new medical therapies for androgenetic alopecia 2022, and I will give you a quick overview of these 4 treatments that are changing the way that we are treating our patients with androgenetic alopecia. We will talk about oral minoxidil, mesotherapy with dutasteride with some new data, oral spironolactone, and oral bicalutamide. Let's start with in my opinion, the most important treatment in recent years for male and female patients with androgenetic alopecia. We are using low-dose oral minoxidil for almost every patient with androgenetic alopecia. We use lower doses for women between 0.25 and 1 milligram daily, and higher doses in men between 1.25 and 5 milligram daily. The most frequent side effect is hypertrichosis, as we are going to see later, but in my personal experience, it's not a problem for the majority of patients, and the safety profile is really good for this new treatment. In fact, we published a few months ago this multi-center study regarding the safety of oral minoxidil for different types of alopecia. We included more than 1,400 patients. We observed that the global rate of adverse effects was 20%, but only 1.7% of the patients had to stop the treatment due to adverse effects. So this is a very low number of patients. Interestingly, we observe a chronological pattern of appearance of these side effects. The cardiovascular side effects appeared early after starting the treatment, like tachycardia, lightheadedness in the first days after the beginning of oral minoxidil, while other side effects like hypertrichosis or fluid retention appeared between 1 to 3 months after beginning the treatment. This is the general scheme of the article. We can see that of the 1,400 patients, only 43 had to stop the treatment, mainly due to hypertrichosis, and other side effects were fluid retention, tachycardia, lightheadedness, and others. But the majority of patients tolerated well this treatment, and these side effects were not a problem for the majority of our patients. Let's talk about this study focusing on the most frequent side effect, hypertrichosis induced by oral minoxidil. We included 105 patients. The degree of hypertrichosis was mild in the majority of patients. The most frequent locations of this side effect were the sideburns and the temples. And interestingly, the mean time between the start of this drug and the appearance of hypertrichosis was less than 3 months in the majority of patients. What about the management of this side effect? Well, interestingly, 40% of patients were not concerned about this effect, and of the remaining patients, some patients used some epilation methods to improve these side effects, and only 4 females had to stop the treatment due to hypertrichosis. So in summary, this side effect usually appears in the first 3 months of treatment. It mostly affects the sideburns and temples. It's usually mild and can be easily managed with dose adjustment of hair removal, not requiring treatment discontinuation in the majority of patients. So based on this research data, this is our proposal of therapeutic management of oral minoxidil in androgenetic alopecia, we can distinguish between mild cases or cases with fear of adverse effects and severe cases with significant quality of life impairment. In these mild cases, we usually start with 0.5 milligram daily in female patients, and we increase the dose after 3 months to 0.75 milligram daily. And if we don't observe hypertrichosis, we increase even to 1 milligram daily. For male patients, we start with 2.5 milligram 3 times a week, and we increase the dose until 2.5 milligram daily. In cases with that are severe, they have a significant quality of life impairment, we start with higher doses with 1 milligram daily in female patients, and we increase to 2 milligram daily and even to 3 or 4 milligram daily. And in men, we start with 5 milligram 3 times a week, and we increase to 5 milligram daily, and in some cases, even with 10 milligram daily. As I have told before, oral minoxidil is changing the way that we are managing our patients with androgenetic alopecia, and we will use it more and more in the following years. Let's change the topic and let's talk about a very trendy topic here in Spain, mesotherapy with dutasteride. Dutasteride is a 5-alpha reductase inhibitor that we are also using with pills, but in the last 5 or 6 years, we are using it injecting in the scalp as a mesotherapy procedure. This is the way that we inject the mesotherapy we do the mesotherapy with dutasteride. We apply a local anesthesia in the frontal hairline in order to decrease the pain of the injections of dutasteride. And after this easy to perform a local anesthesia, we inject the dutasteride in different points of the scalp, on the frontal, mid-scalp, and vertex area, with a separation of 1 centimeter, one point from the other. We use a compound which is 0.025%. There are some marketed products with 0.01%, and it's a very interesting treatment in the private clinic in my practice for male and female patients with androgenetic alopecia. It's not as effective as the oral treatment with dutasteride, but in my hands, it's more effective than other treatments like PRP. Well, let's talk about some recent published data about this treatment of mesotherapy with dutasteride. This article of my colleague from Mexico, Cesar Villarreal, compared 2 groups of patients. The first group was treated with oral minoxidil in monotherapy, and the second group was treated with oral minoxidil plus dutasteride mesotherapy monthly 3 sessions. We could observe that the group of patients treated with oral minoxidil plus mesotherapy with dutasteride obtain a higher response, especially on the vertex area. So we can conclude that the combination of mesotherapy with dutasteride plus oral minoxidil can be interesting for some men with androgenetic alopecia, especially on the crown, which was more effective than oral minoxidil in monotherapy. These are some nice pre-post images of this study, a patient treated with oral minoxidil plus mesotherapy with dutasteride. And the other study that I wanted to discuss is this study that we are going to publish with more than 500 patients that received the protocol of mesotherapy with dutasteride every 3 months. Of the patients treated in monotherapy, the majority improved, with 38% presenting a marked improvement. The most frequent side effect was pain, but it was easily managed with this local anesthesia in the frontal hairline, and there were no serious or systemic adverse effects. So I think that mesotherapy with dutasteride every 3 months can be an interesting treatment as a monotherapy or even as a combination treatment for some patients with androgenetic alopecia. I'm going to show you some pre-post images of patients treated with mesotherapy with dutasteride in monotherapy, like this patient, this man with androgenetic alopecia, or this woman with androgenetic alopecia treated with mesotherapy with dutasteride. We are trying, in fact, some new injectables like bicalutamide, and we are obtaining good responses with the combination of these anti-androgenic drugs plus oral minoxidil. Well, after oral minoxidil and mesotherapy with dutasteride, let's talk briefly about oral spironolactone, because this anti-androgenic drug is a very interesting treatment for female androgenetic alopecia, as this recent systematic review published in the Blue Journal showed. We use doses of 100 milligram daily, and in our hands, it's a very effective and safe treatment with a very good safety profile. I wanted to show you this interesting article about the safety of oral spironolactone in women with personal history of breast cancer, and it was demonstrated that the use of oral spironolactone didn't increase the risk of recurrence of breast cancer. So we can consider oral spironolactone as the oral anti-androgenic drug of choice in this profile of patients. In last place, I want to give you an overview of oral bicalutamide, which is a new generation anti-androgenic drug. It's an analog of flutamide, but with better safety profile, and it improves not only hair density, but also greasy hair or seborrhea. There are some articles that have been recently published with different case series of female patients treated with this anti-androgenic drug. This is one of our patients treated with bicalutamide 50 milligram daily in monotherapy with a very nice response after only 6 months of treatment. Well, these were the topics that I wanted to discuss with you today. Let me finish with our proposal of therapeutic algorithm for androgenetic alopecia in men and in women. For men, our treatment of choice is oral dutasteride plus oral minoxidil, and in some cases, we even add topical minoxidil at night. There are some exceptions, like young patients. In this population, we prefer to start with topical treatment, topical finasteride, plus topical minoxidil. And in patients with early male pattern hair loss, we start with topical finasteride, or we consider the use of low-dose oral dutasteride, as dutasteride is a drug with a very long half-life. We can use only 2 or 3 capsules of 0.5 milligram weekly with a good response in these early cases of male pattern hair loss. In patients afraid of oral treatment, we can consider the same treatment, low-dose oral dutasteride, or even injections of dutasteride. In men with low adherence to topical minoxidil, of course, the treatment of choice is oral minoxidil. And in patients with insufficient response or low adherence to these previous therapies, we consider other treatments like PRP, low-level light therapy, or microneedling. What about female patients with androgenetic alopecia? Without doubts, nowadays, our treatment of choice is oral minoxidil between 0.5 and 1 milligram daily. We try to add topical minoxidil, for example, 3 or 4 nights per week, and we consider the use of oral anti-androgenic drugs. And in these patients, our preferred drugs are spironolactone followed by bicalutamide and dutasteride. In patients with poor adherence to topical minoxidil, depending on the case of this poor adherence, we use oral minoxidil or other treatments like topical finasteride, injections of dutasteride, PRP, and so on. In patients afraid of oral anti-androgenic treatments, we use topical and injected anti-androgens. In patients with signs of ovarian hyperandrogenism, greasy hair, or intense seborrhea, we use these seborrhea-improving anti-androgenic drugs, which are spironolactone and bicalutamide. And in some cases, we even combine a 5-alpha reductase inhibitor like dutasteride and a receptor, androgen receptor inhibitor like spironolactone or bicalutamide. And as I have told before, in patients with a personal history of breast cancer, besides oral minoxidil, our anti-androgenic drug of choice for this population is oral spironolactone. As a second line, we can use in some patients dutasteride, but we are strongly advised to talk to the oncologist first. Well, we are seeing that the treatment of hair disorders, especially in androgenetic alopecia and alopecia areata, is changing over time. It's a fascinating field, and I want to finish with this sentence regarding what Steve just told. The only way to do great work is to love what you do, and I think that all of you love hair disorders. So thank you very much for this invitation. I hope that this lecture has been useful for you.
Thank you very much, Sergio. It was very clear, and I particularly like your 2 treatment proposal for male and female. Let's go to the question. Dr. Buana, do you have question for Sergio? Do you want to take questions we have received from the attendees?
Very nice presentation, as you have done always the same approach. We have various protocol, and I have a question to Sergio. Do you think that all this protocol can be used safely for a common dermatologist faced to a male or female androgenetic alopecia?
Thank you, Pierre. Yes, of course. I think that fortunately, the majority of treatments for androgenetic alopecia, both male and female androgenetic alopecia, have a very good safety profile and can be used easily by a general dermatologist. We only perform, for example, blood analysis for the use of bicalutamide. It has been demonstrated that with the use of oral dutasteride or minoxidil, even oral spironolactone in young and healthy patients, we don't have to run any test and any monitoring. So I think that they are really easy to use treatments and they are really effective. We have to explain to our patients that they have to wait at least 5 to 6 months to see the response. But in my hands and in the hands of the majority of dermatologists, we have a lot of effective treatments nowadays for male and female androgenetic alopecia.
Thank you.
Maybe we can select, I'm going to select a question from the audience. It is now going on the live feed. So this is Dr. Lidda from Greece, which is asking you, Sergio, what will you say is the optimum alopecia effective dose of LEOM?
Well, it's a very interesting question. It will depend on the risk of hypertrichosis that the patient wants to assume. So, for example, if we see a female patient with a severe androgenetic alopecia, we can even start with 2 milligrams daily, because if a mild hypertrichosis appears, the patients will not be worried about it. She can depilate with different methods. But for patients that they don't want to accept any risk of hypertrichosis or any other side effect, we start with a lower dose. My mean dose for female, I would say that is 1 milligram daily. And my most frequently used dose for male patients is 5 milligram daily.
Okay. I would like that if anyone, as a faculty, if you like to give a complimentary answer to the question which is probed to the relevant speaker, please feel free to jump in, you see. We have...
I have a question
yes.
here. That was an excellent talk, an excellent overview. That is, how are you monitoring these patients before you add intervention B to intervention A? Are you doing a hair metrics or a trichogram, or are you just basing it on global photography and patient assessment?
Thank you, Neil. Well, for the majority of patients, we examine with digital trichoscopy, but we perform macroscopic images and we perform this follow-up with the macroscopic images. In the studies, we perform this trichoscopic evaluation with the different methods, mainly with PhotoFinder. But the majority of our patients, they want to see the global result and not just a number and increasing the hair thickness, but to see the first picture, the picture of the current visit and see the improvement.
Well, just one more question. How long do you wait after you begin an intervention before you assume it's helpful or a failure and change to another dosage or another intervention?
Well, we say to our patients that we should wait at least 6 months to see the beginning of the effect, and that the maximum effect is usually achieved after even 1 year. So I will wait at least 6 months to say that the treatment is not effective.
Okay, there is a question from Dr. Dorado Caicedo from Colombia. Dr. Valo, do you have a contraceptive to spironolactone?
Well, in the majority of cases, I don't use contraceptives in combination with the spironolactone. I advise to our female patients that they should avoid pregnancy. And from a hormonal point of view, if I see that the contraceptives are going to be interesting for them, then I add these contraceptives. But I don't use it in every case, and I prefer to use spironolactone alone. And in my hands, it's usually very well tolerated without changes in the hormonal cycle and so on.
Okay. Another question from Dr. Jamni from the Philippines. Microneedling, what is your recommended protocol, and will you recommend steroid or other serum as solution? So it goes a bit beyond your presentation.
Yes, well, microneedling is not a treatment that I'm really used to perform. So I want to know the opinion of Neil.
Maybe Neil, yeah.
Yes.
Yeah.
Neil.
I think anytime you have an intervention that causes some disruption, subclinical wounding, will upregulate cytokines associated with dermal matrix remodeling and stimulation of stem cells in the papilla. However, I found it to be helpful in that stead by itself, but it only lasts for several months. It's a very temporizing type of approach that needs to be constantly repeated. If you add heat, such as using a radio frequency microneedling, then the results are somewhat better and elongated. But the major area where, again, microneedling is utilized is to create channels for transepidermal delivery of any of the products you mentioned. The most common that are used are dutasteride, minoxidil, finasteride, and PRP probably is the most common delivered through microneedling devices today.
Okay. Another question from Dr. Henry from the US. Is the stationary mesotherapy a compound vial or is it found prepared?
Well, it depends on the country. There are some marketed products with dutasteride 0.01%, but in Spain we have to compound it, and we can compound in a liposomal way or between concentrations of 0.01 and 0.1%. We are testing which concentration is better, but it would depend on the country.
Okay. Pierre, do you have another question? Do you want to select a question? Do you see the question coming from the audience, Pierre, or not?
No, no, no.
Okay, so let me choose one. This is again from Dr. Lydia from Greece. Will you combine the steroid and PRP mesotherapy?
Yes, of course. In fact, we do, and it's a very effective treatment in our hands. We combine mesotherapy with dutasteride and PRP in the same session, and in my experience, it's an interesting treatment, especially for female patients.
Okay. Let me look. So I'm going to unselect this one. Okay.
I have
yes, please.
Two questions. First, have you tried Regenera treatment? And second, have you tried synthetic hair, newest synthetic hair implant, hair aesthetics?
Yes, I will start with the second question. I have no experience in it, but from the articles that I read, it seems a little bit risky, but I don't have experience in this synthetic hair. And regarding the Regenera, it has not been useful in my hands. I have tried in a few patients, but it has not been useful in my hands.
Okay.
Another question, Pierre?
No, it's okay for me.
Can I ask one final question, if that's all right?
Please.
Excellent talk. So to my way of thinking and understanding, and from the research that I've done, the etiology of hair loss in men and women are somewhat different. The etiology is less understood in women. The 5-alpha reductase story is pretty well accepted in men. So our research is looking at the role of inflammation in women, and the major targets that we're gearing for, in addition to things like minoxidil and PRP, are anti-inflammatory targets. What is your feeling about that? Because a lot of the same treatment options that you mentioned, you use different doses in men and women.
Yes, completely agree, Neil. And the world of the field of the microinflammation is really interesting. And in fact, we in some patients we use a topical steroid once weekly, and we have better experience with some patients with, for example, trichoscopic signs of inflammation when we add these treatments to our patients. So I think that, for example, PRP does work fine in some patients with this mild microinflammation, and I think that there will be new targets regarding this mechanism of action. What are your thoughts? I'm really interested.
We biopsy all of our women with hair loss, both for H&E, histopathology, as well as for immunofluorescence. And we found a very common pattern of immunoreactivity of IgM and granular deposition of IgM positivity along the stem cell areas in bulge and papilla zones. And we sort of segregate our women into diffuse female pattern hair loss with or without inflammation. If there's evidence of microinflammation on the biopsies and some immunoreactivity, we tend to use some of the approaches that we've talked about, like combination of minoxidil plus topical steroid. And I like using red light therapy in that setting as well as an anti-inflammatory target. I think more work needs to be done after all of our Northeast dermatopathologists to really examine their specimens more carefully, and for our doctors to do immunofluorescence to see whether we can come up with any consistent pattern of microinflammation that's associated with hair loss, particularly in women. And last comment is I think that the term of androgenetic alopecia in women is not such a great term to utilize, and I only utilize it in women that have hair loss associated with some hyperandrogenetic type of clinical or laboratory evaluation that shows evidence of some androgen excess.
Thank you so much for your thoughts.
Dr. Vano, last question before jumping to Dr. Sadiq's presentation. From a question from Dr. Moyal from Canada. What is the depth of dutasteride injection?
Yes, very interesting question. Thinking about the histology of the hair follicle, we try to inject the dutasteride injections in about a 3 or 4 millimeter depth. In fact, we use a 4 millimeter needle and we inject in 45-degree inclination in order to apply this dutasteride in this area of the hair root.
Okay. Sorry for the audience because we are not able to answer all the questions. Although at the end of the webinar, if we have time, I will come back on the pending question.